We're filming.
Hi, I'm Dr. Jerry Hesch, a physical therapist at Hesch Institute in Aurora, Colorado. And our client today is being treated for several things, including a side bent coccyx, and we've already filmed that. You can find that posted on YouTube. But what I wanted to demonstrate now is a so-called anterior ilium. If you read the literature on treatment of the sacroiliac joint, you'll find a description of an anterior ilium being a pattern in which, for example, the right ilium rotated forward on the sacrum and became stuck. And we know from research that there's only 2 millimeters of glide and only about 2 degrees of rotation in the sacroiliac joint. So if it were to rotate that much, it would be too subtle for me to perceive that visually. Okay? Furthermore, if it were to rotate in that direction, you would have rotational asymmetry at the pubic joint. Now, she has an asymmetry of her pelvis, and I don't know if the camera angle will capture it or not, but her right ASIS is anterior towards the ceiling. It's easy for me to perceive from this angle. If I come underneath it, this ASIS is inferior, and that's quite obvious, okay? If we palpate the pubic bones, there's no asymmetry there. And if we test posterior rotational mobility, she has good mobility on the left. And if we test on the right, you'll notice I can hardly take up the slack. What little movement is there is taken up very, very quickly. And I'm using about 15 pounds of force, the same amount I used on the other side. And now I'm doubling that force and trying to induce rotation, and it's not moving. And I suggest that this is a pattern of the entire pelvis just being twisted on the hip joints. I don't believe that it's rotation of ilium on sacrum. All right, so let's have you lie on your stomach, and I'll show you 2 other movement tests. So if the pelvis is twisted in this manner, then superior mobility would reinforce that movement, that propensity to move anteriorly on the right. And if we come and look at her shelf, her iliac shelf is higher. If we look underneath the ischial tuberosity, she's higher on the right side. And if we induce anterior rotation, she moves well. Okay? But because the whole pelvis is twisted to the left, in which the right side is elevated, then this movement will be absent, and in fact I cannot take up the slack, so I cannot induce any inferior spring mobility. On this side, we can take up the slack and spring inferiorly. Okay? So this is very easy to self-treat. Would you lie on your back, please? And the self-treatment involves you taking this hip, this knee, grabbing it with both hands and stretching it outside of the shoulder.
Okay.
Okay? And we do this for 2 minutes. So I will set a timer. And I think we'll just keep filming. And there is a lot of controversy regarding the sacroiliac joint. But I think it's really important to look at the science. And the highest standard of evaluating joint mobility is inserting titanium pellets, like BBs, into the various pelvic bones, and then taking a film of that called stereophotogrammetry. And that test has been done several times on extreme movements of the pelvis and hip and trunk. And again, it only reveals movement in the sacroiliac joint on the order of 2 millimeters of glide, give or take a small amount, and approximately 2 degrees of rotation, give or take a small amount. And again, visually, I don't believe that I can perceive 2 millimeters of difference side to side and I don't believe I can perceive 2 degrees of rotation side to side. And so we have to ask what else is possible, what else might be going on. And the whole pelvis can move on the heads of the femur. And so I think that a reasonable explanation is a lot of these patterns of pelvic asymmetry, you know, which are treatable, which are mutable, that there's an alternate explanation for them. And we certainly need more research on the benefit of treating it. You know, there's certainly a huge knowledge gap, but she presents with pelvic pain, and therefore we're going to treat her trying to restore normal mobility throughout the pelvis. And go ahead and move the camera a little bit so it won't... Oh, that's not the camera, that's the timer. Sometimes the camera beeps when it's ready to shut off if it thinks we're not doing anything with it. Let's put your leg out straight now. And so this is a very, very simple stretch that the client can do. And there's definite improvement in symmetry. I can now take up the slack and I can induce passive mobility. Okay? So this concludes my presentation on right anterior ilium. Thank you.